He's a consultant in glaucoma and anti segment in precise specialty eye care. He did his MD ophthalmology from RP Center AIMS.
Change your time.
And he graduated as a best resident. He continued there as a senior resident in glaucoma and cornea. He has conducted several talks and been part of the organizing committee of several state as well as national conference. Over to you, sir.
Can you change the time to 12 minutes?
My talk is for 12 minutes.
The time is 12 minutes. Please reset the timer to 12.
Set the timer to 12, please.
Okay, welcome everyone. The focus of my presentation would be the octopus perimeter, and we will try and look at the various differences between the more widely used Humphrey perimeter and also discuss the pros and cons. It's not moving. Okay, the octopus was actually the first automated perimeter that came in 1974. The Humphrey came almost a decade later. The most widely used model of octopus is the Octopus 600, which is on the left of your screen there. You can see that it's not a cupola-based perimeter like the Humphrey. This is a screen-based perimeter where the patient looks into a screen through those rings which I have marked in the photograph. Now, from the machine perspective, there are some advantages, like this can be operated under daylight conditions, and that it's a silent perimeter, doesn't have the motors of the Humphrey, which can be distracting for some patient. Now, you can feel that the absence of a liquid trial lens like you have in the HFA3 can be a disadvantage because it helps in faster setting up times. Now, with the Octopus, nobody actually looks at the printout. You have the iSuite software that is installed on your desktop. So through single clicks, you can get any kind of representations you want, whether it is 7-in-1, 9-in-1, 4-in-1. You can, just single clicks are required. But for easy understanding, I have just used a baseline of a 7-in-1 representation of a patient for simply easier understanding. Let's start with the examination parameters. You notice that I have here used the 24-2 pattern. This is basically for the sake of continuity. But the Octopus does give you the advantages of having some optimized patterns for glaucoma, like for example the G pattern. You see that the G pattern points are more in the central and the paracentral area. And also the distance between the points are not equidistant. As you move away towards the periphery, the distance increases. The closest equivalent would be the 24-2C pattern of the Humphrey, which was already described, where 10 extra central points are tested. Let's look at an example here of a patient where 24-2 pattern is done. Only a couple of abnormal points here, which you probably dismiss that as normal. But the same patient's G pattern is immediately picking up a cluster of points in the center. The patient does have an infratemporal RNFL defect and inferior thinning, thus helping us to pick up a diagnosis of glaucoma earlier with the G pattern. Similarly, for the 10-2, you have the M pattern, which again tests more points in the center. Now, if you look at the test strategy, I have employed in this particular patient the top strategy, and you also notice that the time taken is 1 minute 33 seconds. So this is in terms of time taken equivalent to the Sita faster. But unlike the Sita faster, this also tests fixation and also tracks false negative errors. Unlike the Sita faster strategy, the equivalent to the Sita standard would be the dynamic strategy. Now, I'm not going to the details of false positives, negatives are all same as the Humphrey, but fixation control is something that I think merits a mention here in Octopus. The Octopus has so many methods of fixation control. It tracks pupil, dart, automated eye tracking, blink, and contact. What this essentially means is that if the patient is feeling fatigued, he can simply close his eyes. The machine will automatically stop, and once he opens, the machine will restart. This is why a lot of people who have unreliable results on Humphrey can get actually reliable results on the Octopus. Now we look at the representations. Most of these representations are simply differences in terminology. There are some only minor differences. Now the values representation is the same as the threshold values on the Humphrey. There is no difference at all here. Comparisons is the same as the total deviation numerical map. But one difference in representation, you will see a lot of plus signs here. Now those plus signs are points where there is a sensitivity loss of less than 5 decibels. They're not very important. I feel this is a better representation because immediately looking at the comparisons, you know the pattern and the shape of the defect, because all the numerical values indicates that there is a defect there. Now the grayscale in the Octopus is different in two aspects. One is obvious, it's a color scale rather than a grayscale, it's color coded. The other difference is that the grayscale on the Humphrey is based on the threshold values, whereas this is based on the comparisons of the total deviation. So this actually has greater value. Now, if you look at the probabilities plot, it's the same as the probability total deviation probability map in the Humphrey. And similarly, corrected comparisons and the corrected probabilities are essentially the same as the pattern deviation numerical map and the pattern deviation probability maps. But what is unique to the octopus representation is something called a defect curve. I'm not going to the technical details of how this is plotted, but a normal defect curve will lie between those two parallel lines as shown in the figure. And if the patient has a diffuse defect, the curve will shift downwards in a parallel manner. And if you have a local defect, it will drop towards the right, and both will happen in a combination of local and diffuse defects. There are other patterns for hemianopia as well, but this is essentially a snapshot. One quick look at the defect curve, you know whether this is a local or a diffuse progression. Now, if you look at the indices, there are 5 indices. The one at the bottom is MS. It's not very important. Let's look at the important ones. The MD, or the mean defect, is similar to the mean deviation, representing both local and diffuse loss. The square root of loss variance is again similar to the pattern standard deviation of the Humphrey and represents local loss. The 2 other indices which are unique to the octopus called the diffuse defect index and the local defect index. Now these are calculated from the defect curve I showed earlier, and that is why they are unique to the octopus and represents diffuse loss and local loss respectively. Now, the 9-in-1 representation of the octopus has 2 other features. One is called the cluster analysis and the other is the polar analysis, which are unique to the octopus. Now, cluster analysis is very sensitive for early defects. It basically divides the entire visual field into 10 different clusters based on the patterns of the RNFL bundles. Let's understand this with an example. If you look at this patient's left eye visual field and you look at the corrected probabilities, let's look at it in a zoomed up manner. There are only 2 abnormal points as per the criteria described. You would dismiss this as normal. But the cluster defect analysis shows the significant cluster defect in that particular region. As you can see, it's color-coded also for easy understanding. And the patient does have a supratemporal defect that will correspond to the cluster defect in that patient, again replicated on the OCT as well, thus helping us to diagnose glaucoma at an earlier stage with the cluster analysis. The polar analysis is a kind of a software trickery to give you some function structure correlation as well. It helps you to identify where you want to look for the changes in the optic disc. Based on this principle, let's look at that point in the visual field with 13 decibel sensitivity loss. Obviously, that will have a corresponding representation in the optic disc. So if you look at our base patient and you look at the polar analysis, you see those long red bars in the infratemporal region. That is where you want to look for the optic disc changes. The newer software also gives an ONH projection analysis through a single click on your computer, and that will also tell you that it's the infratemporal region. That is where you want to look for, and exactly that is where you find the defect. There's a large infratemporal defect. That is the beauty of the polar analysis. And the octopus does have an HFA style printout also for easier transition. For people who wants to transition to the octopus, it's the same printout will be given in the HFA style. So the terminologies will now be the same as the Humphrey, which is for easier understanding, but it will lack all the unique features of octopus. It will not have the defect curve, the cluster analysis, the polar analysis, all the extra indices that you get. But if you look at, therefore, a single field analysis, all I can think of are actually pros, because you have more optimized patterns like the G and M pattern. You have a cluster analysis, which is again very sensitive to detect early defects. The polar analysis and the ONH projection gives you function structure correlation. The defect curve snapshot, you look at the defect curve, identify what kind of a defect the patient has. Everything is more color coded, and I feel it's better aesthetically also. And you have the HFA style printout also for easier transition. So these are the advantages. I couldn't find a single con as far as the single field analysis is concerned. Coming on to the progression analysis. So this is how a representation of the progression analysis looks like. So on the bottom you have the color scale of an overview of all the color scale of the fields which you have used for progression. And then the trend analysis of the 4 indices which we have already described. And then you have on the top right cluster trend analysis and the polar trend analysis on the bottom right. So, if you look at the trend analysis, again, all the trend lines are color coded. If you see there, except the diffuse defect, all the three other indices are coded red. That immediately tells you that this is actually worsening. And also, apart from the color coded trend lines, you have those patterns which I have marked there, for example, that tells you if it's worsening at p less than 5 or p less than 1. Again, so intuitive to understand just by looking at it. Now, also, depending on the indices worsening, you can make a distinction between local and diffuse progression. For example, if it's a diffuse progression, you will have a change in the MD and the DD trend lines. And the local progression will have a change in everything except the diffuse defect. And with diffuse and local, you will have both. Now, you also have now the cluster and the corrected cluster trend analysis. This is helpful for detecting subtle localized field change, and also, unlike the trend lines, it starts giving you spatial information of where this is happening. So this is our base patient example. You can see that it is the 3 supranasal cluster area that is actually worsening in this particular patient, and the color coding is again pretty clear. The inverted red triangles tell you that it's actually worsening in those areas. This does not really require an explanation. You immediately look at it, you understand this is where it is worsening. Now, the polar trend analysis and the ONS trend analysis again links functional progression to structural progression. Again, from our base example, does not require any explanation. The infratemporal region, you can see those long red areas. That is where the progression is happening. The projection trend analysis also shows those 3 inverted red triangles, telling you it's that area of the patient's optic disc that is undergoing the progressive changes. To summarize the progression, so you have the collection of the fields, which is the color scale of comparisons, which is again very important. From that itself, you can understand that, okay, it's in that area, the supranasal area, which is actually showing the progressive worsening. The trend analysis immediately tells you that apart from the diffuse defect, all the 3 other indices are worsening. So this has to be a local progression, right? The diffuse defect is not remaining the same. Now, the cluster trend analysis tells you that, okay, it is those areas which is actually worsening, those 3 supranasal areas. And the polar trend analysis and the ONH projection trend analysis tells you that in the infratemporal region of the optic disc, you are going to face the progression in this particular patient. Now, if you compare the IC394 versus the GPA, there are some advantages versus disadvantages. First of all, an advantage is that it's more comprehensive trend analysis. The GPA gives you the visual field index only. This gives you all the 4 indices. Now, the polar trend analysis again gives you a function structure correlation, which is pretty unique. If you notice, the octopus employs only trend analysis. Now, one could argue that this is more resistant to more outliers, which you get in your clinical practice very often. The first 2 fields may be wrong, then the 5th field may be completely out of whack. So this is more resistant to outliers, but that is where one disadvantage also comes. The IC394 software in general is also, as you notice, is color-coded, it's easier and more intuitive to understand. But the difference is there is no point-to-point event analysis. Right? But the GPA has a lot of pedigree also because it is derived from the EMGT. And the point-to-point event analysis is considered to be very sensitive for early detection, as has already been mentioned by Dr. Ratni. And therefore, that can be considered as a con. I thank you for your